This is an introduction to musculoskeletal ultrasound brought to you by the Department of Physical Medicine and Rehabilitation, University of Cincinnati College of Medicine. Objectives include advantages versus disadvantages, echogenic properties of tendons, muscle, ligaments, and bones, high versus low frequency transducers, and understanding the phenomenon of anisotropy. Common uses of ultrasound include evaluation of tendons, muscles, nerves, and its use in interventional procedures. Listed are multiple benefits of the use of ultrasound. Highlights of this list include portability, the use of non-radiating waves, and its relative low cost. Limitations to ultrasound include anisotropy, which we will discuss in detail later, in addition to expertise in anatomy, as well as the potential for errors in both performance and impression. We will start with some of the echo terminology. Hyperechoic is the term that refers to things that are bright under ultrasound. Bone tends to be the most bright of the tissues, followed by tendons and ligaments. This short-axis view of the dorsum of the wrist demonstrates the scapholunate articulation. The carpal bones are bright and hyperechoic, with no wave penetration deep to the bright cortical echo. Isoechoic reflects as gray, such as muscles and nerve axons. Isoechoic reflection is demonstrated by the large round nerve fascicles noted in this short axis view of the median nerve. Hypoechoic or anechoic, meaning without brightness, is demonstrated by fluid and cartilage. The ulnar artery and vein are the oval hypoechoic structures just left of the pisiform bone. Transducer frequencies commonly utilized in musculoskeletal diagnostic ultrasound include low-frequency curved array and higher-frequency linear array transducers. In general, the higher the frequency of your transducer, the better the resolution. And the lower the frequency of your transducer, the deeper the penetration. So this leads to a frequency-resolution trade-off, where the curved low-frequency transducer tends to give you deeper penetration but lower resolution. Conversely, a high-resolution transducer gives you better resolution but a relatively superficial field of view. The above picture demonstrates my preferred method of holding a transducer with 3 fingers bracing the transducer against the patient's skin. The following are a few dynamic movements in order to best optimize the image. Toggling is moving the transducer up and down along the short axis of the transducer. The heel-toe maneuver is moving the transducer along the long axis of the transducer. Heel-toe is demonstrated over the long axis of the wrist tendons. The sweeper scan keeps the image on the screen while gently sliding the transducer along the course of the structure to be visualized. So you may ask, how does ultrasound work? We'll talk about 2 things. One, the piezoelectric effect, and the second, the reflection of sound waves back to the transducer. The piezoelectric effect stimulates crystals in the transducer with an electrical current, which vibrate and then send sound waves through the conducting gel and into the tissues. These sound waves are then reflected back from the tissues to the transducer, and the reverse of the piezoelectric effect transforms these sound waves into digital pictures. Sound waves reflect back to the transducer at tissue interfaces, such as the intersection between subcutaneous tissue and tendon. Resolution is optimized if the structure is perpendicular to the wave propagation, such as a ball being thrown against a wall. Left to right are high and low frequency transducers. The downgoing arrows are to represent sound waves leaving the transducer and going through the tissue. In this view, the upgoing arrows represent the reflecting sound waves that are transmitted back to the transducers. You may have noticed that the reflected sound waves and upgoing arrows have dimmed. This is to represent that the majority of sound waves are refracted and not reflected back to the transducer. This phenomenon is called attenuation. Only a small percentage of sound waves are reflected at the first tissue interface. Sound waves continue to propagate deep into the tissue, reflecting at subsequent tissue interfaces. The longer arrows noted at the curved transducer are to represent deeper penetration with a low frequency transducer. With all wave propagation and reflection accounted for, we will first focus on the high frequency transducer. The solid coloring of the returning arrows is to represent the excellent resolution with high frequency transducers. However, the shortened arrow length is to represent the reduced depth. The deeper arrows on the right side are to represent improved depth of transmission with the curved transducer, with the speckled appearance representing reduced resolution. This image represents the long axis view over volar wrist tendons. From the top of the image you can see soft tissue and then the fibrillar wrist tendons, and below the carpal bones. This is a short axis or transverse view through the buttock region, where at the top of the screen is subcutaneous tissue, and then gluteus maximus, piriformis muscle, and sciatic nerve. To the left side of the screen is the bone shadow from the sacrum. Bone is the most hyperechoic of structures since all waves bounce off of it. As a result, there is no imaging deep to bone. This is sometimes called bone shadowing or posterior acoustic shadowing. This picture demonstrates a short axis view through the supraspinatus tendon, which is in the middle of the screen. There is a bright white arc which demonstrates the humeral head. On the left side at the 10 o'clock position is a short axis view of the biceps tendon. Building the picture superiorly from there is the supraspinatus tendon in short axis, the deltoid muscle in short axis, and subcutaneous tissue. Imaging deep to the humeral head reveals anechoic signal. The longitudinal appearance of tendons under ultrasound can approximate that of dried spaghetti. The short axis view of tendons appears like looking at the ends of dried spaghetti or a brush. Here the transducer is placed longitudinally over the long head of the biceps tendon, and this is its appearance just to the left. Turning the transducer 90 degrees brings about a short axis view which shows the on-end appearance of the spaghetti or the biceps tendon in the groove. So in both pictures, D is for the deltoid, BT is for biceps tendon, H is for humerus. The top picture is longitudinal and the left is proximal. So again, it's subcutaneous tissue, deltoid, biceps tendon, and then the humerus with the anechoic area deep to the humerus. The inferior image is in short axis with left being medial. The bright object is the biceps tendon and below that is the humerus. The deltoid muscle is just above and subcutaneous tissue is on the very top of the image. This is a long axis view of the wrist flexor tendons seen in the middle of the screen. Below are the carpal bones. This is a much thicker tendon and long axis view, the quadriceps tendon. Noted by the arrow, the quadriceps tendon is inserting into the patella. To the right is a short axis view of the quadriceps tendon. You can see the top of it, the most superficial portion, demonstrated by the arrow. And finally, another tendon in long axis view. This is the Achilles tendon, outlined by the arrows inserting into the distal calcaneus. Now for some pathology. From the left side of the screen is proximal along the distal Achilles tendon. You will notice some hypoechoic or dark areas where the tendon attaches to the bone. This is an area of delamination or tendon degeneration. You will also notice on the right side, in the short axis view, denoted by the arrows, some dark areas or hypoechogenic areas, which reveal areas of tendinopathy as well. Next is the echo appearance of muscles. This is the short axis view of the distal arm just above the elbow. Building the view from the top reveals the biceps muscle and below the brachialis muscle. The neurovascular bundle is in between the muscles. The humerus is noted as a hyperechoic crescent at the bottom of the screen. Different muscles, even in the same area of the body, have different internal architecture. This can be seen here where the brachialis muscle on the bottom has more hyperechoic areas that represent connective tissue, or more stars. Superior to that is the biceps muscle, which appears to have less connective tissue. I've demonstrated this effect on the right side using a very lean or New York strip steak on the top to demonstrate the biceps muscle, and a T-bone steak on the bottom, which has more marbling or connective tissue. Similar muscle architecture patterns are readily seen in the leg. This demonstrates a short axis view through the medial posterior leg with the medial gastroc superior and the soleus muscle inferior, both demonstrating a starry night pattern. Same muscles with the transducer turned longitudinally. The muscle orientation remains consistent with the medial gastroc superior and the soleus below. The orientation of the fiber bundles and connective tissues resemble a leaf or a feathering pattern. These long axis images reveal longitudinal views of the proximal hamstring muscles. The image on the left is the patient's unaffected side. The right image demonstrates hypoechoic clefts that suggest muscle tears. Last but not least, we will review the echogenic properties of nerves. Nerve connective tissue, such as epineurium and perineurium, reflect as hyperechoic or bright signal in cross-section. Fascicles are hypoechoic or dark. Nerves therefore give a honeycomb appearance in short-axis views. Nerves in the long-axis view resemble a tram track appearance, or in some cases they can resemble a long piece of licorice. When a structure's shape is not completely perpendicular to the vector of the sound beam, a portion of the structure is not well visualized. This phenomenon is called anisotropy. In every image, some structures in the field of view are not well visualized. The key to sonography is to optimize the visualization of the object of interest. The insertion of tendons on bone, seen here with the distal Achilles tendon, is typically out of focus due to its curving path. The simple technique of following the course of the structure with the transducer allows us to fill in the picture by changing the sound beam angle of isonation to correct unwanted anisotropy. As we will see later, the reason I use the term unwanted anisotropy is because some anisotropy can be helpful in discriminating between similar looking structures. This cartoon demonstrates how sound waves are reflected back to the transducer when the subject tissue is perpendicular to the sound beam and is relatively straight, depicted here as a long axis view of a long bone. When the tissue of interest is no longer perpendicular to the sound beam or curved, the waves are refracted away from the transducer, causing the interrogated tissue to appear hypoechoic. This last cartoon is to further depict the phenomenon of anisotropy. If we assume that the angle of the transducer is held fixed in place, yet the imaged object becomes less perpendicular to the sound beam, there is reduced reflection of sound waves back to the transducer. Therefore, this depiction of short axis evaluation of a round bone requires that the transducer is moved along the curved edges in order to perform a complete interrogation of the area of interest. So let's put this all together based on what we've learned in this movie. Sometimes anisotropy can be our friend, allowing us to improve the image of one of the structures while dimming some of the others. Demonstrated here is one of the toggle maneuvers we discussed in order to reduce the resolution of the underlying tendons while improving the resolution of the median nerve. It's hard to know whether or not on the left side the tendons have been torn or whether or not this is anisotropy. What we're demonstrating is using the heel-toe maneuver, we can fill in the area of anisotropy. In this view, the hyperechoic honeycomb-shaped structure in the middle of the screen is the median nerve. I've purposely evaluated this nerve proximal to the wrist, where it's surrounded mostly by muscle, in order to contrast the view and see it more readily. Utilizing a distal sweep or scan maneuver, the nerve can be followed all the way to the carpal tunnel, resting above the tendons under the flexor retinaculum. It's my hope that you've enjoyed this basic review of musculoskeletal ultrasound. Thank you for your attention.